This is Dr. Saurabh Galagly in Monterey, California. On behalf of the Endospine Academy from Balgrist University Hospital in Zurich, Switzerland, and from Arthrex Spine in Naples, Florida, I'd like to discuss the topic of medial branch transection after radiofrequency ablation. This is an emerging indication for endoscopic spine surgery. Many patients are referred to us after the second or third radiofrequency ablation when that percutaneous procedure becomes unsuccessful, in an attempt to achieve more effective and longer lasting pain relief by endoscopic division of the medial branch of the dorsal ramus. Here we have a three-dimensional computer representation of the human spine, and I've used that red line to illustrate the curve of the superior edge of the transverse process becoming the superior articular process. And if we make that dissolve, what we can see is in a human specimen, here the L4-5 facet joint, when viewed from the surgeon's perspective standing on the right side of the patient, we can see the medial branch of the nerve labeled MB on this diagram diving underneath the structure called the mammalo-accessory ligament. Here in yellow is the medial branch, and here in a white parallelogram is the mammalo-accessory ligament, which creates a fibro-osseous tunnel which the medial branch travels underneath. The therapeutic goal of this procedure is to interrupt that branch, and that can be done either by endoscopic means or by percutaneous radiofrequency ablation using heat. This is a busy slide illustrating the relative effectiveness of both. On the top, we have the visual analog pain scale, and on the bottom, we have the Oswestry Disability Index. We have 6 months post-op, and 12 months post-op in the two rows. And each vertical bar is one patient representing a waterfall plot of their clinical results. The red patients are endoscopic, the blue patients are percutaneous radiofrequency ablations, and the take-home message here is that the taller the bar, the greater the pain relief. So for example, in the endoscopic group here shown in red, 2 patients were able to achieve 100% pain relief, indicating that their visual analog pain score went from 10 out of 10 to 0 out of 10, or 8 out of 10 to 0 out of 10, for example. Here is the 50% pain relief threshold, which is the dotted line. That goal is achieved by 90% of the patients treated endoscopically and 36% of the radiofrequency group, and that treatment effect persists for longer in the endoscopic group, going from 6 months to 12 months. Technically, what this translates it to in my multidisciplinary practice is that I will do a fair number of patients that come to me for endoscopic treatment of the medial branch, either without having a previous procedure or after having 2 or 3 previous radiofrequency procedures done by one of my pain management colleagues. Endoscopically, this is what the procedure looks like. Here we'll zoom in on the patient, navigating to the L4-5 facet complex on the patient's right side. This is the normal clinical anatomy. Here we have the superior edge of the transverse process becoming the superior articular process. Here's the medial branch of the nerve going over the top of the facet, and the mammalo-accessory ligament will be located over here. Here what we're going to observe is that the nerve is covered in perineural fat, and it's relatively mobile and free in this space. And here I'm using the radiofrequency probe in order to be able to dissect that nerve out from the surrounding tissue in advance of dividing it. So this is normal anatomy. Here the nerve is relatively mobile and free, and you can see there's a relatively large amount of perineural fat in the area. In contrast, this is what that scene looks like after 3 or 4 previous attempts at management of this condition with percutaneous radiofrequency ablation. The nerve is still visible. Most of the perineural fat has been removed. This area is now relatively immobile. The nerve is still scarred down and can be manipulated with a nerve hook, but you can see that the surrounding area around the nerve is relatively avascular. Most of the fat has been melted away by the previous application of heat. And here we're mobilizing the nerve. And here, this is a very interesting finding that I see frequently after previous percutaneous radiofrequency ablation, is that the mammalo-accessory ligament is actually calcified. So first I'll use a pair of scissors here to divide the nerve, which is shown here. So there's surgical division of the nerve. You can see that the nerve is still very much in continuity. And the benefit of this procedure in terms of making the pain relief more permanent is we'll now use the radiofrequency probe to shrink the edges of the nerve back, resulting in a division of the nerve of greater than a centimeter. And now what we'll do is we'll place the retractable ball tip probe underneath the mammalo-accessory ligaments. Let's just back up there and look at that one more time, because this is a critical part of the anatomy here. So if I hit pause here, previously the area where we divided the nerve was down here, and now I've reoriented the camera, And you can see that the fibroosseous tunnel that the nerve was traveling underneath, and I'm using a retractable ball tip nerve hook in a retrograde fashion in order to be able to demonstrate the tunnel that is created by the mammilloaccessory ligament where the nerve travels. A pulled back view here illustrates the top of the transverse process, bottom of the transverse process, mammilloaccessory ligament here, and the previous trajectory of the nerve located like this. And here I'm just cleaning up the final little bits of soft tissue in order to be able to complete that picture. And generally the surgical appearance of these after, so there we go, let's pause right there. So there's the surgical field there, where we see the curve of the superior articular process becoming the transverse process, the previous course of the medial branch going underneath the mammilloaccessory ligament. And that area has been now cleaned down to the periosteum. So the summary here is that this is an extremely effective procedure. I personally have been able to achieve significant pain relief in patients who met very good inclusion criteria for medial branch transection. And the clinical vignette that I commonly see is that the patient will have 2 or 3 percutaneous radiofrequency ablations with shorter and shorter intervals of pain relief. They're then referred to me by a pain management colleague. And in situations like this where I can identify and divide the nerve, I feel like I'm usually able to achieve a significant degree of pain relief and clinical success.